So welcome to our live conversation from One Cancer Place, the culture of connections. Today, Dr. Chris Heery, the CMO of Arcellx, hosts a conversation with Dr. Chloe Atreya. Dr. Atreya is a medical oncologist who specializes in gastrointestinal cancers, particularly colorectal cancer, at UCSF Helen Diller Comprehensive Cancer Center in San Francisco. So Dr. Atreya and Dr. Chris, let's have a conversation.
Great, thank you, Erica. Well, it's my pleasure to be here again. Today we have a special guest, Dr. Chloe Atreya from UCSF, as Erica just told you. I would usually start these things out by just letting our guests tell us about themselves from their own perspective, things they have worked on, maybe a bit of their journey and the things they're really passionate about, and we can go from there.
You know, I first wanted to be an artist. My father's a scientist. There are no people in medicine in my family. And I think that art has been a big part of my journey and continues to be. And I got interested in science early on because of my father. He studies the outer planets, and I wanted to do something that was much closer to Earth, and to things that were tangibly affecting the people around me. And so instead of using telescopes to look out at the planets, I was interested at looking, microscopes, looking in at the cells in the body. And so I studied both biological chemistry, pharmacology, and also visual art in college, and then went on to do an MD PhD program. So again, this bridging role, and I chose and was fortunate to be able to do my training at Yale, which also had a wonderful art program. So I continued. I probably am one of the few people who chose their MD PhD program based on the art school, but it is true. So pursued a PhD in pharmacology, and it was during my medical school training that I became really interested in cancer, and that was really because of the patients that I met, and I knew that I wanted to take care of whole people, that I didn't want to just focus on one organ. I wanted to practice medicine that affects everything in a person's life, and to be there for that, and also to work on the science. So I was actually focusing. My PhD project was on protozoal parasites, but it was a pathway that is really important for the metabolism of 5-fluorouracil, which is a backbone of chemotherapy and colorectal cancer and many other cancers, especially GI cancers. And so my PhD committee included experts in colorectal cancer. And so I think that's how I got to a focus on colorectal cancer. From there, I did my residency at University of Washington. I really wanted to get out to the West Coast, where I've settled. And then for choosing residency, I came to San Francisco. My undergraduate advisor, Kay von Schokat, who is a chemist who's a pioneer for a lot of the targeted therapy drugs that have been approved for treatment. He was at UCSF, and I was meeting with him and decided to come back, in part so I could do a postdoc in his lab and my oncology fellowship at UCSF. And I've been here at UCSF ever since, and starting really, working primarily on the targeted therapy side, which I still do. And yet over time, I've been trying to find ways to incorporate more of the art of medicine into my practice. And so I now co-direct the Integrative Oncology program at UCSF, and work on bringing a lot of mind-body practice into oncology care.
That is an amazing story. I did not realize some of the things that contributed to the picture that is you. So that's really fascinating. I wondered if you could maybe, for the audience that may not be as familiar with certain terms, maybe we could just highlight a couple that you just used. So targeted therapy. Could you maybe talk through what that is just at a high level? And we'll come back to that a little bit more in a bit.
Sure. Yeah, I'd be happy to. So with targeted therapy, so cancer cells have something about them that is abnormal, that allows them to keep growing and dividing in a way that's uncontrolled. And sometimes that can be like an on switch in a motor that's always on. Our targeted therapies are generally small molecules that are targeting something that's abnormal in the cancer cells, and it's often trying to shut something down that is kind of perpetually on, and in that way trying to shut down the growth and division of these cells. Sometimes we also think of it as kind of like a lock and key, so these molecules can be very specific for a mutation or a change that occurs only in the cancer cells. So it's a little bit different than our conventional chemotherapies, which are generally targeting any rapidly dividing cell. It's more targeted or precise.
Yeah, so I think that's a great overall just sort of definition for the audience. I was hoping that would lead us down the path of how do you think of targeted therapies then in terms of this broader idea about integrative medicine and personalizing therapy for patients? Could you maybe walk through how those things are related?
Yeah, for sure. Yeah, so they're both ways of personalizing medicine, and the targeted therapy is kind of more on we call it like the precision medicine side, so that kind of lock and key idea, and these are anti-cancer therapies. And then I think about the integrative modalities, which include mind-body therapies like meditation, yoga, qigong, and also practices like acupuncture and systems of medicine like traditional Chinese medicine. And those it's a more holistic approach. So it's personalized medicine, but accounting for the whole person as opposed to this like lock and key. And then I also think about it as a pro-health approach as in contrast to like purely anti-cancer approach.
Yeah, I wanted to maybe go a little bit deeper on that because I think for some patients, they often don't have a clear concept of what cancer actually does physiologically, like what the impact is across different organs in the body. And even the definition that you shared of cells sort of growing out of control, I think is a very simple definition that most people can understand, but isn't necessarily the definition that most people have heard throughout their life, right? Or maybe they've never really heard a definition of cancer. They just know it's something they're scared of. Could you kind of maybe talk through how, and I mean, we can use colorectal as the example since that's where most of your clinical work is, but how different presentations in different patients might affect their organ function or their symptoms differently, and how you would approach those things with one patient to another. For instance, if somebody has metastatic disease in the lung, they may have a different array of problems than somebody who has metastatic disease in the liver, and so on. And so as you think about sort of integrative care and dealing with symptoms, I assume that similar to how you personalize therapy, you're also personalizing the symptom management. I was just wondering if you could kind of talk through the different resources you might use in different patients depending on the symptoms they present with.
Yeah, so starting at maybe why colorectal cancer, let's say, can have different presentations. Part of that can relate to what particular mutations are present. So these changes even at the cellular level can predict where the cancer cells are most likely to go in the body. And then depending on where the cancer cells are in the body, that can impact the particular symptoms that one might have if it's in the lining of the abdomen or the lungs or the liver. And so our treatments may be different based on both the location of the cells and also the biology of the cells, and those two are intertwined. So that's on the kind of biomedicine side. And then in terms of the integrative oncology side, we would take that into account, and also the whole person beyond the cancer. So, part of that, there can be things that are very directed, like if someone's disease is mostly in the lungs and taking a deep breath is difficult or emotional, that we may change a meditation practice so that the object of meditation may not be so much on the breath. So some of the sort of tailoring of the integrative oncology practices, and similarly, traditional Chinese medicine and acupuncture have a whole way of looking at the whole body, not just what's the location of this particular disease, but kind of the whole physiology. And then it's also accounting for people's emotional makeup, what practices resonate for them. Many different factors that make up a person and what they may take up and may derive benefit from, and some of those may precede ever having a cancer diagnosis. I don't know if that's getting at your.
No, that's great. I a couple of things you said really made me think about one, how you see the sometimes perception that Eastern and Western medicine are opposed to each other. I'd love to hear, you seem to be firmly planted in both of those worlds. And I'd love to hear sort of one, how that's worked at your institution, but also maybe getting that to be something that could be done in more institutions, because I think there's great value there that most patients could see. I'd also love to hear if you've had patients who visit you primarily for one or the other and are kind of like, I don't want to hear about the other side of that. And whether over time you've seen patients sort of come to see the value of both approaches to medicine.
Yeah, so I practice integrative or complementary medicine, which is taking together with the biomedicine and these other approaches, which is a little bit different than alternative medicine, which may be kind of like an alternative to what we're calling biomedicine. Biomedicine being most of what Western medicine with chemotherapy and immunotherapy and those sort of things are. And so in an integrative, so in terms of differences in what we'll call Western or biomedicine, we do have a tendency to try to break things down into, this organ or this mutation or, this particular symptom or problem. And in other systems of medicine, which again can include traditional Asian medicines, and Ayurveda is another one. There's more of an integration of all of the systems together so that everything is impacting each other, and it's also an integration between the individual and the environment. So there's a more porous kind of relationship between the person and the environment. So it's kind of less split up into all these different organs and more taking it all together. So the approach to even like what in Western medicine may be a particular symptom, say nausea or numbness and tingling, might be different in traditional Chinese medicine or acupuncture approach from person to person, because it's not just about that particular symptom, but it's like everything about that person's constitution that may be individualizing their experience of that symptom. So I am interested in an integration of both approaches. I think that so the traditional medicines are, I think, most valuable for trying to keep things in balance. When things are really out of balance, like when a cancer has developed and metastasized, it's, in my opinion, harder just to use those approaches to try to control or eliminate the cancer. And I think that we can work hand in hand with modern science and traditional science that's thousands of years old, and the wisdom that's there to support the whole person and their body. And so I don't think they need to be opposed. Your other question about whether people come to me for one or the other, yes, it happens. And I think for people who are coming more for an alternative approach, I think that having someone who's open to both sides, sometimes then I've had instances where not being kind of like shut down, like devaluing that the alternative or alternative approach can help someone accept an integrative approach. And that sometimes if they feel like their providers are, just squarely in Western or biomedicine, that their values aren't being addressed, and it's harder to accept any of those treatments. And so trying to meet halfway. And sometimes people come for just a Western, best in targeted and immunotherapy type of approach, and learn that they can also benefit from an integrative approach. So I see that also.
Well, it's particularly interesting too, because I think some of your background, particularly in pharmacology, I think is where oftentimes there can be a real detachment between people in the medical profession and sort of the lay public. And I wanted to maybe just give a brief definition of what that is, right? Because I think most people don't know what that is. So in really broad terms, pharmacology is the study of how drugs or substances that go into a person's body are going to distribute around the body, and then the effects that drug will have from what we call mechanism of action, or sort of what it does in the body, what cells it affects. And so you can measure both what is called pharmacokinetics, which is the distribution of that drug, and pharmacodynamics, which are the effects of that drug in the body. And I wanted to mention that because I think when we as physicians think about a drug, we are often thinking about pharmacology, especially the medical oncologists are really thinking about pharmacology. That's primarily the way we think about things. It's a lot of the training in oncology. I think that's fair to say. And I think it also leads to what can be a predisposition in Western medicine to assume that any non-pharmacology reviewed therapeutic or agent could ever work because we don't really know all the isolated variables about them. And I'd love to kind of hear your opinion, as you've been in both worlds, about teas, or I mean, just things that are maybe, a little less well defined from a pharmacology standpoint, whatever it might be, and what effects they can have, and what generalizations or what specific use cases you can think of for those sort of, I don't want to call them therapeutics, but, agents that are not necessarily prescription drugs that might be used for symptom control, or historically might have been used in even treatment of diseases like cancer.
It's a great question, and it's a great observation that in pharmacology, the kind of Western pharmacology, we're trying to control all of the variables. So just change one variable at a time, so that we can really kind of narrow down like what is the effect of this particular chemical in this particular situation. And so this trying to have this very controlled experiment, and that's how we develop our evidence for what works. And that's a challenge in integrative medicine, because even in there's pharmacology in, say, traditional Chinese medicine as well, and yet in Ayurvedic medicine, and yet it's very much on the kind of the wisdom of plants in some way, that there's a wisdom to how all of the chemicals in a particular plant and in a combination of plants work together. And in traditional Chinese medicine, they actually kind of talk about it in terms of like a government, and like the different roles that people might have in a government. Of like, there's, I don't remember the specific roles, but like having a combination of drugs together that are playing different roles. And that's actually key, is that these phytoceuticals, or like all of the different chemicals that are in a plant, and then these plants together, is where the therapeutic benefit may be coming from. And it's been very hard for Western medicine to try to like tease that out in a reliable way, to say, is this composition of this compound exactly the same batch to batch? And do we know within this group of chemicals what's doing what? And for the FDA, for instance, to approve something, they really want to narrow it down. Like we know exactly this one-to-one correlation of cause and effect, and that's not necessarily the way that it always works. And I think that it is a challenge, and it's also a challenge because we don't necessarily know how these groups of molecules play with particular chemotherapies and other drugs that we may be giving for supportive care. And so it becomes hard to advise patients because we don't have kind of solid data either on effectiveness or toxicity. And I think it's a really interesting area. I actually have focused more on mind-body therapies because there's a lot of evidence for benefit, and there's not a lot of evidence for, there's not a lot of risk of harm. There are, some potential harms of meditation. There are times, especially when people have a history of trauma, for instance, that we need to be careful about how we introduce these practices. But it's not the same sort of like, are we going to be interacting with the chemotherapy drug in a way that either increases the toxicity of the drug or decreases the efficacy? Those sort of unknowns we don't generally have to worry about with things like meditation or yoga. And so I've been focused more on sort of harnessing the benefits of those, as well as there's a lot of data supporting a diet that is filled with a variety of vegetables, in particular fruits and whole grains. And so rather than my focus personally, rather than being on supplements or on kind of plant-based drugs, has been more on a plant-based diet, and as much as possible trying to eat a diet that has a whole variety of has a whole variety of colors, because actually the colors of all of our food reflect the chemistry, and the more colors, the more colorful our plate, actually the more diversity of our microbiome based on the diversity of the chemistry of the foods that we're taking in.
I just wanted to come back to a couple points there. So specifically looking at food or derivatives of plant material or any other material in nature as a potential therapeutic for cancer. I think this is something people think about a lot, and there's just an enormous amount of guilt that also can be heaped on patients with cancer around diet and all kinds of things. I'd love to hear your thoughts on that point, and then maybe I can come back to the next thought that I had on that. But I'm sure you see that a fair amount, that people are getting advice from all different directions about what they should eat and what their friend read on the internet and everything. And how do you take on that conversation?
Well, in the group medical visits that I've created for patients, we touch on this idea of a varied diet, and it's a diet that has anti-inflammatory properties. But I actually focus more on mindful eating, and so more on like how of eating than the what in some way, and kind of like what is our relationship to food. And there are practices that we can do to slow down eating, and these can help with a lot of symptoms that come up both with cancer treatment and with cancer symptoms, and can help to like improve digestion by slowing down and really paying attention to chewing. And so there's this one thing that many of us, myself included, have noted. There's a concept of like layering of food that happens, where we tend to be in this kind of fast-paced society, and it's kind of like one bite after another, and we end up layering one bite on top of another. And there's a practice of putting down the utensil between bites and not picking up that spoon, fork, chopsticks again until that the previous bite is fully chewed and swallowed. And a lot of us notice that we've had this practice of layering one bite after another. And then another mindful eating practice is a couple. One is kind of treating food as a medicine. So sometimes food is not pleasurable when eating may not be pleasurable due to either symptoms related to the cancer or the treatment. And so trying to change the relationship from it being about like eating for pleasure to like this food is actually part of my medicine, my treatment. And then also the practice of giving thanks and like looking deeply into the food and all of the interconnections that brought us this food from where it was grown and me picked and brought to us, and thinking deeply about that can also change a relationship to food at a time that it may be difficult and change what it was before undergoing cancer treatment.
Yeah, you mentioned the topic of microbiome, and I wondered if you would like to expound on that just a little bit more. I'm sure many of the viewers don't really know exactly what that is and how food could affect it. Are you willing to kind of walk us through those concepts?
Sure. I can start. It's a really complex area that we're just scratching the surface on understanding. So there are about 3 trillion different kinds of bacteria in our gut, and that's an enormous community ecosystem that lives in our gut. And there's microbiome in other parts of the body, but again, I focus on colorectal cancer, so I'm pretty focused on the GI tract and the gut. And it's known that dysregulation in the microbiome, say with an illness, with an infection, can be one risk factor for developing colorectal cancer. And so what can happen is that there can become like an inflammatory environment in the gut. And part of what's contributing to that inflammatory environment is the interaction between these microbes and the immune system. And so there can be like all of this inflammation that develops, and then some of the normal physical checks and balances in the body can break down. So physical barriers can break down, and then along with that, some of the signaling checks and balances on cancer growth can go awry. So the microbiome, we know, plays a role, at least for some people, in the development of colorectal cancer, and we hypothesize that with the unfortunate rapid rise of colorectal cancer in young people that we're observing, which isn't explained by a change in genetics. We think it has to do with lifestyle factors that are affecting the microbiome. And then once cancer develops, the cancer itself can impact the relationship with the microbes, and can change the composition of the community. And then, of course, our cancer treatments can also have an impact, as well as the food and activity that we engage in. And so we're still trying to tease out, all of those impacts. But immunotherapy has been one area that's been, I think, pretty definitively shown that there's an interplay between response to immunotherapy and the gut microbiome. And this is another area where I don't think we're smart enough to know like the right probiotic mix in terms of like us trying to, impact the structure of the community. And that right now, anyway, the best approach is like really diverse fruits, vegetables, whole grain that supports the microbiome to be as diverse as possible. Because like human communities, the more diversity that we have, actually, the more kind of robustness and resilience the microbiome community has. And we'll see a decrease in inflammation, and can support the immune system to work to help to control the cancer.
Yeah, I mean, that is an amazing overview in a short period of time to give. I mean, I think most people hear these terms and really don't have much of a concept. But one of the things that you touched on that I think is, for anybody would be very difficult to argue with is the idea that eating a diverse diet should drive a diverse collection of microbes that live in the gut. And for anybody who wants to connect those two thoughts, you can think of it like each one of those microbes is going to preferentially choose different nutrients out of foods or different chemicals out of foods. And so if you supply all one type of food, then you're going to enrich for one population or one group, one type of microbe that is more likely to feast on whatever it is that you eat all the time. But if you eat lots of different things, then lots of different microbes can find their niche in that population, and then therefore may impact things like how our gut interacts with those populations. And then we know that how our gut interacts with things in it affects how our immune system functions in the rest of our body, which is actually fairly confusing biology, but it's real. And so there's also this concept that if you haven't spent any time on this, we can certainly skip it. But there's this concept of gut signaling directly impacting neurophysiology. I am certainly no expert on this. I know very little about it, but I wondered if that's something that's come up in your practice at all. That foods can impact mental health almost directly. It seems like people are discovering more and more about this all the time. And if you are comfortable talking about that, could you also talk about how you think about customizing diet to that approach in individual patients, if that's something that people are starting to work on? I honestly don't know.
Gosh, when you're bringing that up about the impact on neurophysiology, honestly, like what's coming up is so from a personal standpoint, recently I've been developing migraines, which is a really common ailment that a lot of people have, and it's just been very clear this gut brain axis that can happen with migraine physiology, which is also thought to be impacted by the microbiome in some way. So I don't know if anyone else can relate to that. You don't have to like raise a hand sort of thing, but it's such a common thing that maybe some people can relate to that like experience of those two being tied together. The microbes produce chemicals. Those chemicals can act kind of like hormones or neurotransmitters. That's one way that it's thought that the gut and the neurophysiology, like sort of the nervous system, may be tied to the microbiome, and I'm sure there are others. Chris, did you have anything you wanted to add about that?
No, I wish I knew more about that, honestly. I just didn't know if that was becoming part of the integrative medicine approach to try to, I mean, I know there are very selected labs around the country that are very, very interested in understanding the reciprocal communication between the brain and the gut, that appears not only to be sort of the electrical signals that travel up and down axons, but also, as you mentioned, chemically driven signaling processes by chemicals in food. And I've even heard hypotheses that, that there may be the ability to diagnose certain, say, psychiatric illnesses and customize diet in a therapeutic fashion. Obviously, I think we're still in very early days of this, but I wondered whether, that would be something that, in addition to thinking mindfully about eating, which, by the way, putting the fork down between bites is something I probably need to put into practice as well. I tend to eat just like as fast as possible and get to the next thing. So no, I just wondered if that's something, if it's still in early days and it's not quite there yet. That makes a lot of sense. But it seems like as we understand these types of things, we might understand more about why Eastern medicine had so much success before there was pharmacology to explain it. And I just wondered if that was something that has started to percolate.
Yeah, it's not my area of expertise, and I agree with everything that you said, and I think it is starting to percolate. And like I have colleagues who focus on aruvedic medicine and really trying to customize diets to individual physiology, and I think that our understanding of where that's coming from in terms of the descriptions of Western science with neurophysiology and immunology and things like that. I've definitely seen papers that are coming out that are trying to start to explain why these practices that have been practiced for millennium have continued, because there's a basis there, and Western science is trying to catch up on that. I think we'll see more of it in the future.
Yeah, I wondered also then, just from a couple of things you've mentioned along the way, do you feel at all, I mean, obviously you're very specially trained compared to almost anyone out there. Do you feel any sort of obligation to try to bridge the gap between those who only want their Western science and those who only want sort of, Eastern medicine, and try to bring those two things together from a scientific and and maybe, I don't know what the right word is, but also from just like a holistic approach. Like, do you feel at all like compelled to try to drive this narrative more across all of oncology? And if so, sort of, how do you think about getting there? I mean, it seems like a really tough hill to climb. It's a lot of people are kind of one camp or the other.
Yeah, it's a challenge. It's something we talk about a lot. And part of what is a challenge is that in biomedicine, a lot of what we learn from is say patient estimates. So a blood draw, a stool sample, a tumor biopsy, right? And when I'm teaching meditation, I'm teaching yoga, qigong, these kind of holistic practices, it feels at odds to be like, okay, let's do this meditation practice, and then can we draw your blood after? Can we take some stool afterward? And so I've struggled with that. Honestly, it changes the experience if we're changing that container from being really focused on being true to the practices and being respectful of these ancient practices, and really trying to communicate in a way that is potentially helpful, and trying to really get into the scientific explanation that requires that we do a bunch of monitoring measurements and take this and that. So I haven't actually thought about it, and in some ways, since I also work in the lab and do all this targeted therapy stuff, that in some ways I can see why it makes sense, but I feel like that hasn't been how I've been trying to bridge it. I've been trying to bridge it in terms of trying to be authentic in both areas.
Mm-hmm.
And and then working on guidelines. We can still study what we call patient reported outcomes with integrative oncology. So we can without taking specimens from people and doing a bunch of scientific methods, we can do interviews, and we can do some surveys, and so there is still a way to show benefit in a way that is respected by Western science. And so, for instance, right now I'm on the joint guidelines of the American Society of Clinical Oncology and the Society for Integrative Oncology. So we're developing joint guidelines of integrative practices for anxiety and depression. And so most of the high level evidence that's showing benefit is based on patient related outcomes rather than the base changes. And yeah, that's where my focus is, because I think we can disrupt the process if we're interfering to obtain samples.
I'm really fascinated by the two worlds that you're trying to join. And I think if it were me in your place and I knew all the things I would be so focused on trying to prove the scientific concepts with laboratory data, and I would, like you said, I'd probably miss the ability to actually get the best outcomes for individual people, because you'd be disrupting a lot of that. So, I mean, I imagine along the way that you've had grant applications for sort of trying to tie some of the physiologic aspects that you can measure to the emotional well-being, integrative aspects that are delivering clinical benefit for patients. And I mean, maybe you have one even that you're working on now, right? I mean, maybe some of this work is under a grant. I guess the reason I'm asking is, I could imagine that there will be people that watch this episode and say, gosh, I wish someone would put more money behind this. How does that happen? Are there specific grant funders out there that focus on integrative medicine, that if people wanted to donate their energy or their time to support, that they could say, oh, I want to go find out about that organization. And, it's, no fault of like the NCI, which is where I used to work, or, the American Cancer Society, or any of the big ones. But, sometimes they're more interested in the things that are much more straightforward scientific. And so a long way of asking, is there an outlet for people who are really interested in what you're doing to support it?
It's a great question, and it's something that we've struggled with a lot. Is trying to decide if we're going to try to make what we're doing fit a grant mechanism, or if that doesn't fit with what we're really most interested in doing. So we've my colleague and I have had many hours of conversation about these type of things. Like like this type of mechanism always includes a mechanism aim, and yes, we could do it, but would we believe in the results, and would it positively or negatively impact the rest of what we're doing? And we actually haven't ended up putting in any applications that have that mechanistic basis. I have many mechanistic grants with the NIH are separate from this, but we do have things that definitely include surveys, include diet and lifestyle changes, and actually, there are some that include surveys plus dual collections, because we are working on the microbiome. And actually, a lot of this work relies on philanthropy at this point. It's something that resonates with grateful patients, fortunately for us, and so we've been fortunate to have support from grateful patients that have really supported me to do this work, more so actually than grants so far. I've had small institutional grants and that sort of thing, but it's, I think the grant mechanisms aren't necessarily haven't yet caught up with what is important to people.
Well, that's true of so many things. So I also was wondering then, how do you recruit people to come and work in an integrative practice like this? I assume there's some level of self-selection that people seek you out and say, look, I think this is an important part and I want to learn from you. Is there a need to recruit more people into the field in general? And if there are people out there interested, aside from you, are there other practices around the country where people could learn some of these practices?
Yeah, that's a great question. And UCSF has what's called an Osher Center for Integrative Health, and there are several different Osher centers around the country. And the Osher Center is where I received my formal training in integrative medicine. And so there are training programs that are associated with Osher centers, and some other universities have integrative medicine training programs, sometimes integrative oncology, but more commonly, more generally, integrative medicine. And so that's a way people find us, through the Osher Center. And there's absolutely a need for more integrative medicine, integrative oncology providers specifically. It's one of those things that, at least in the Bay Area, most of our patients want to take an integrative approach, and people who have means are often seeking it outside of the Comprehensive Cancer Center. So I've been advocating a lot that it needs to be part of comprehensive cancer care. And in order for it to be part of what we offer as a comprehensive cancer center, there has to be availability. And that's sometimes been difficult with a limited number of providers. And so what I've been doing recently is really expanding the group medical visit offerings that we have, so that, like this morning, I was working with 8 patients together, and it allows me to work with more people. It's also, I think, a really important, people are learning from each other. So everybody has their own wisdom that they're bringing to it. And often people with the cancer diagnosis feel like alone and kind of like siloed, and may, not trust their inner wisdom. And so I found that these groups have been really well received, and part of that is really empowering patients to teach each other, and we learn from them as well. So we're at UCSF, what we're actually doing right now is expanding the group medical visit offerings to try to serve more people. And I'm really focused on serving people who haven't had access to integrative oncology previously. So most of the work has actually been done in breast cancer survivors, which is wonderful. And actually, particularly white breast cancer survivors is what most of the prior, integrative oncology has been. And that's, I think it's a population of convenience. There's a lot of interest there, and that's great. And yet our patients who are active treatment are usually, you really have to tailor practices to make them relevant and accessible for people who are in active treatment. And so that's really been my focus, is active treatment patients, and then also making these practices relevant and accessible, especially to our patients who are people of color, and otherwise may have social economic constraints such that they're not able to access the same sort of resources that other patients do. So that's been a major focus for me. The groups that we've run so far, we actually reserve half of the slots for patients who identify as BIPOC, and that's important also in terms of forming community. So part of feeling a sense of belonging is feeling like there are other people like you.
Well, I mean, it's just it's incredible. I mean, the amount of different topics that you have become an expert on over the years, and the way you're trying to pull all of those different needs together at once. I think I can speak for the rest of the audience in saying I think we all wish there were more of you in the world. It is clear that this is a real labor of love for you to try to pull all these things together. So I will speak for the group and say thank you for everything you do. And I really, I hope that somebody who hasn't previously considered integrative oncology as something that could meaningfully impact outcomes watches this and says, I'm going to email Dr. Atreya and ask how I can learn more about this, maybe in my own practice, or maybe I'll go do a training program and bring it back, or whatever it might be. I have to say I learned a lot from this conversation, so thank you for sharing all of this. I wanted to see if any of the audience members have maybe a question or two for Dr. Atreya before she has to leave there. Sarah, go ahead.
Yeah, hi, Dr. Atreya. So you were my husband's oncologist, and I was fascinated with everything that you did, obviously, with getting the Enhertu like that and testing. But some questions that I have, what are the major barriers that prevent integrative oncology from being practiced in a more mainstream way?
One of them has been a limited number of providers that are truly practicing integrative care, so that it's not siloed, like people are getting their alternative medicine and their
Right.
biomedicine. And so I think that's one of them. And I think that, again, these kind of like funding mechanisms and having the powers that be really listen to patients in that this is something that they want as part of comprehensive cancer care is something that we're still working on. And I think that it's starting to be heard, but so far maybe hasn't been as much as of this. It's not like big money like biopharma,
right.
Within HER2 or with the immunotherapy drugs.
Right.
On the ground, person to person.
Right. And if patients are interested in integrative care, what is the best, and it's not offered at the local cancer center, how would you recommend that the patients identify a way to kind of navigate themselves into something?
Yeah, that's a good question. One good thing with the pandemic, I would say, is that there are more online options. And there's a group, I think it's called Anti-Cancer Medicine, that had a lot of resources that I think are high quality selection of resources.
Okay.
So some of the online options I think are good. I do encourage patients to link up with advocacy communities such as this one.
Right.
And
right.
I think that can be helpful for sharing knowledge,
just sharing information. I love that you have a group of people at the hospital that you're working with, because I think that's so invaluable, and because of HIPAA we aren't able to connect like that, and I think that's brilliant. So the third question I have is, how can a patient talk to their doctor who's not necessarily open or knowledgeable to integrative?
That's a good question. That's a really good question. I don't mean to laugh at the question. It's just kind of like, wow, I haven't. I think an open-ended question about what they think about it, and it can kind of try to establish where both people are. I think that if it can be kind of if we can try not to make assumptions on either side,
right,
that can be helpful. I think sometimes patients will assume that the doctor's not open to it, or the doctor will assume something about the patient, and neither is helpful. And so I think as much as possible, having kind of just like an open dialogue about what their thoughts are and what the resources available are, and that sort of thing.
Yeah.
I wish I had a better answer to that. It's a great question.
Well, yeah, it's just, Julie came up with that question because she, I think she's very open, but I don't know that, and you can speak for yourself, Julie, but that's something that you've obviously run into as a patient. So.
Yeah, I submitted the question to Sarah just because this is an area that I'm personally involved and invested in. And I talk to many patients who are curious about this, but often are maybe the oncologist just isn't knowledgeable, and so quickly kind of will turn them, not turn them away like in a bad way, but just redirect them away from some of these efforts. And so I think, people aren't exactly sure what to do when they approach their oncologist with something who is supposed to be the leader of their care team. And it's something that they're interested in, and the oncologist kind of isn't supportive. And so I hear that a lot from people that are interested, and so they're just not quite sure what to do in that type of a situation.
I mean, I think it's helpful to have a team One thing I can say as an oncologist who also specializes in these, targeted therapies and that sort of thing, is there's never enough time to go over everything. And so even having the knowledge, part of the reason, I don't have knowledge about everything, right? Like, people want the, very tailored diet. I'm not the best person for that. But that there's never enough time. There's all of this data and things on the web and this and that. And part of what's also confusing is, like, when we look at the National Comprehensive Cancer Center guidelines that we're supposed to practice with, and it says there's a category 1 or highest level of evidence recommendation for yoga for cancer-related fatigue. It just says yoga, as the list. And so for a practicing oncologist, what does that mean, in terms of, and so that's in our groups, is like really trying to explain, like, when we're talking about yoga for sleep and fatigue, like, what are asana or postures, poses that can help with sleep? What are ones that can help address fatigue? That's like kind of it's a nuanced discussion that takes practice as well as time, not just as discussion, but actually experiential practice. And so that's where I think that we need to have also these other venues, like the group medical visits, that can expand what we offer, because we just can't do everything in the medical oncology visit, which isn't to make excuses for oncologists that, like, shut down communication. But I do think we really need, we need team approaches for comprehensive cancer care.
UCSF has a fantastic team. I think that experience for us was between you and Dr. O and everybody. I think that was we were very lucky.
I'm glad you feel that way. I mean, I feel, it's really still evolving, and
it's progressive for sure.
It's progressive for sure. Yeah.
I think one other comment I would just make, as somebody who maybe doesn't have as many restrictions on sharing opinions like this, is that, we've talked on these programs before about seeking second opinions, and not really being afraid to say what you want. I think as patients, oftentimes, there is a general sense that the doctor knows more than you do, and they probably do about chemotherapy, right? They probably do about targeted therapy. It doesn't mean they know more about what you want in your life. And so if you want something, you have to say, this is what I would like. And if someone says, I'm not going to help you with that, then find someone else who will. I mean, I know that sounds very simple, and I know that it's a full-time job being a patient or a patient's care provider. But at some point, you also have to say, if I'm not getting what I think I need, I will look elsewhere for it. And there's nothing wrong with that. And I would even say, having been in the position of having patients ask me for things that I didn't know about, I would say, can I help you find somebody who knows about that? Because I don't know. And I think that's the other thing. It's sometimes very hard for physicians to say, I don't know about this. And so that's why I can't help you, because I don't know anything. But if they don't know, they're not going to figure it out for you in that moment. So you probably have to do some of your own digging to figure it out. And I know that's not easy, but I just thought I'd share that it is a lot for physicians to keep up with all the various things going on in research, integrative medicine, et cetera. And so everyone can't be an expert in everything.
Yeah, that's true. And I mean, I want to recenter again cancer disparities, because, one thing I've seen in inviting all of the the patients who are BIPOC that I'm seeing to these groups is that those patients may feel less empowered to ask those questions, that may be met with distrust from physicians and people that I had no idea they'd be interested, like really engage in these practices once given the opportunity, and so I think that we also as a medical community need to be proactive in being inclusive. Because otherwise we end up, continuing to center resources on people who may, have more empowered to advocate for themselves.
Well, I want to be respectful of your time, Dr. Atreya. Thank you so much for joining us. If you have more time, we can stick around and answer more questions. If you need to go, that is also great. And we thank you again for joining us. It's been just an incredible conversation for me. I learned a lot, and hopefully our audience did as well. So thanks again.
Great. Thank you so much. Thank you for your interest, for the great questions. To be here. Happy to take questions offline as well. Take care.
Great.
Might I say thank you so much, Dr. Chloe. It's been wonderful. Thank you.
My pleasure. Thank you so much for the invitation.
You bet.
Thanks.
Let's do it again.
All right.
Thanks. Wow.
All right.
Chris?
That was
Chris,
awesome.
that was wonderful.
Yeah. So much there that, you don't learn in oncology training. It's almost, I was trying to get her to talk about this a little bit more, but it's not just that it's not taught, it's that it's like actively dispelled. And I think some of you have touched on that in the comments. Like, for a lot of oncologists, this is like voodoo, and they would rather sort of attack it than try to understand it. And I think there's a lot to learn from somebody who is as rooted in science as Dr. Atreya is, who is also as heavily rooted in integrative medicine. It's kind of the ideal scenario for somebody that helps to bridge those gaps. And I like that she said, I don't really think about it that way. I just do the best I can to help patients. I mean, it's probably what we should all be doing, but it's just the honest truth from her perspective. So that was great.
Chris, may I ask a quick question?
Yeah.
And that is, I don't understand the term BIPOC.
Black,
Okay.
Indigenous, and people of color.
Yeah.
I've seen it both ways.
Okay.
Yeah, I was trying to think if there were any other terms that she mentioned that weren't defined.
I'm glad she actually defined integrative versus alternative.
Yes.
Yeah.
I think there's, even among those people who practice patients who participate in integrative care, myself included, and I think the line between what is considered integrative and what is considered alternative is often pretty blurry. So I was glad that, she focused on that a little bit, because I think that would help people who are kind of learning about this space.
Yeah.
This is such a case of words matter. When I hear a patient making a move to talk about, I want to talk about alternative care,
Yeah.
it raises my hackles, because I know that what they're really meaning is something alternative to the only choice I have, yet they don't know the right word to use. And people don't seem to make a distinction between the word complementary and integrative on one side and alternative. And so my take on it usually is to say, seek out complementary and integrative, I can't even pronounce it, along with, find someone like Dr. Atreya. That's great. And
just one in a million, Erica. They're just
that's kind of the problem.
Yeah.
I mean, there literally are probably a handful of Dr. Atreyas out there.
Well, we got one.
Yeah, but so sometimes it's hard for people to go do that. I know in my case, I've had to thread together a team that I feel like has the qualifications to bridge these gaps, because it's just not an option for me at my local cancer center.
Like I said, UCSF is so progressive with how they do things and everything that they do. They have like she was saying, they have the whole integrative medicine center there, and
I'm here in Midwest US. It's going to be a while.
Yeah. I know.
But that's okay. There are other ways to get it.
Yeah. Well, you can come out here, Julie.
Would love to.
I'd like to point something out here. everybody, and that is, she mentioned a couple of times the group medical visit. I wonder if you all heard that. She's talking, and I want you all to know that it was my great uncle, the doc in Boston, who is known as the father for medical group therapy. He's the first person to see the benefit for doing it. And so I'm excited about talking to her about that. I mean, basically, it relates to what we do in our communities, our patient communities. We get together, we learn together from one another and from other people. And I can tell you that my great uncle's story about the idea, the insight, was that he was walking to his clinic one day in Boston and saw his patients waiting for him in the clinic, and they were all yucking it up and exchanging stories in the anteroom of the offices. And he noticed that. He noticed their cheeks were pink and they were having a good time. He also noticed that when they came in individually to see him, that they became pale and sick again. And he said, aha, I'm going to start talking to them in groups and mobilizing them when they're feeling good and teaching them and everything that needs to be done. And I'm sure that is what is happening in the group medical visits. I'm so encouraged to hear that.
Well, I think, it just goes to show that we all have so much to learn from each other. I mean, oncologists can go to school for as long as you need to and read the book, and you can cover every ounce of that book, but you've never lived with cancer. You don't, have that part of it. And then, you've got the person who's living with it that has never read about it and has no idea what a cancer cell, does in the body. And you've, got to kind of bring it all together. And that's no simple task, but I think we have a lot to learn from each other. And I think it's, that's significant.
I don't know, Chris, you're in charge. I mean, does anybody else have any more questions to ask Dr. Chris?
If you were going to find some alternative provider outside of medical oncology, and, it's going to be hard to get reimbursement for that. I think it's a huge challenge. I mean, there's not a solution here. I think if we want to see those things change, then there has to be more effort through lobbying, through advocacy foundations. I don't know how else that begins to change. But I think the other thing that sometimes people get a little caught up in, I was just having this conversation with a friend of a friend whose mother was recently diagnosed with a type of cancer that I've been doing some work on for a while. And, she was like, hey, we want to get a second opinion, but our insurance won't let us go to these 3 other places in the city we live in. And I said, well, then just pay for it, right? Like just pay the $500 for the one visit and get the other opinion. And yeah, it's $500, but like, if you can afford it, do it, because it'll save you months and months and months of wondering if you did the right thing. And it might save you money in the long run to have spent the $500 on this instead of something that will lead you down a path that isn't the right path. And then you end up like going on a million other visits later. And she was like, oh, can you do that? Can you just pay cash? And I was like, yeah, you can just pay cash. And I don't think most people know that you can just, like if somebody says, hey, we're not taking your insurance, you can say, okay, well, here's a check. And then you take the money out of this and then return the rest to me when I'm done, right? Like that's every major academic medical center will let you do that. But you do have to write the check up front so that they know that they have the money if they need it. Like, for example, I had a surgery not that long, like 3 years ago, and I had to write a check for the whole surgery until my insurance reimbursed me for the thing. And like, I have good insurance. So you can see how like this is sort of standard practice. These big places expect to be paid. And I would just say that is one other thing that I don't think most patients know, that sometimes you can just spend, it's not insignificant amount of money, but it's oftentimes worth it if you just want to pay out of pocket to go see an expert somewhere that your insurance doesn't let you go.
Yeah.
Not a solution for everyone, I should point out. Not everyone has access to $500 to go have a visit like that. But if you do, and it could save you a lot of heartache, it may be worth it.
I was wondering how many oncologists would be willing to talk to that integrative person that you're working with, because oncologists are busy. I don't know who pays for the visit or something, but how how open,
How can you
what's
get
the
them?
possibility of that?
Yeah, I mean, I wish I knew the answer. I think I'll give you an honest answer from my perspective. When I was at the National Cancer Institute for 7 years, we have a fully trained integrative medicine team. I don't know if I ever referred a patient to them. And just being totally honest, like I don't think I ever did, because it never crossed my mind. Nobody ever asked. I just didn't ever do it. And then I was lucky enough to rotate with the bone marrow transplant team, and they use the integrative medicine team like all the time, literally almost every patient, so Reiki, massage, and acupuncture, and they just had everything as sort of part of the care. And I think it's more than anything is just getting used to doing it, just making it part of what you do every time you see a patient. I think you could make the same argument for people meeting with palliative care from the very beginning. Whether or not they have a curable disease, it's still valuable to think about palliation of symptoms all the way from the start. And I think most of us just get too busy. We get into our own patterns and we don't do it. It doesn't mean most doctors aren't willing to do it. They just have to change their pattern, right? So I don't know if that answers the question, but I think sometimes patients bringing it up helps a doctor rethink what they've been doing. So I wouldn't be scared to bring it up. Thanks for setting that up, Erica. Honestly, really, really educational for me. So I always like learning new stuff. So thanks for setting it up.
That is so great, Chris. Dr. Chris, we are so grateful to you. I want you to know, all of us, for your continuing support and participation in what we feel are, is the development of a true learning channel for anybody interested in any matters regarding cancer and its experience. I'm going to thank everybody for in attendance, but I want to make sure that we all know to thank our founding funding partner, which is the Seagen company out of Seattle. And then our funding partners are Natera and Mirati and the Colon Cancer Coalition and the Colorectal Cancer Alliance. Without all of their support, we would not be able to do this, and we are most grateful. So that all being said, everyone, thank you so much for showing up, and we'll look forward to seeing you for our next live conversation, hosted by Dr. Chris Heery and another very special guest. Thank you.